Hello, dear friends. My name is Dr. Saf. Today, we are going to discuss an important and interesting case of abdominal sepsis. 30-year-old obese women who presented to the emergency department with complaints of pain in abdomen in the right lower quadrant, along with low-grade fever. And ultrasound abdomen showed appendicular lump for which she was operated. Okay, so this is the appendicular lump which was diagnosed on ultrasound. And later on day 10th of post-operative day, she again developed high grade fever and disorientation. On examination, patient was found to be febrile with oral temperature of 103°F. There was a tachycardia. However, the blood pressure was normal, and laboratory investigation showed total leukocyte count of 21,000, neutrophilic predominance of 90%, hematocrit 38%, creatinine 1.5, and lactate 3 millimole per liter. So with this information, we went ahead and performed an abdominal CT scan, which showed evidence of abdominal wall abscess, and this is the CT scan. You could quite well see over here the situation, a lot of pus which is there inside abdomen. So probably this is the case of complicated intra-abdominal infections, which is type of abdominal sepsis. And today we are going to discuss this in detail. What is intra-abdominal infection and what are the types of intra-abdominal infections? Intra-abdominal infection is the second most common cause of sepsis after pneumonia. Intra-abdominal infection is defined as the local manifestation that occur as a consequence of peritonitis. However, it can also arise from gynecological or urinary tract as well. So the classification is like this. It can be of two types, uncomplicated and complicated intra-abdominal infections. So in uncomplicated intra-abdominal infection, only single organ is infected and infection is contained inside the peritoneum. So that's a definition, very important definition of uncomplicated IAI. They have usually the good prognosis and require clean surgery along with antibiotics. So that's all they require. But sometimes they may progress to complicated intra-abdominal infections, okay, which have poorer prognosis, in which the inflammation extends beyond the organ and causes either localized or diffuse peritonitis. And they may require definitely the surgery, emergency or urgent surgery. So the examples of uncomplicated intra-abdominal infection could be appendicitis, very common, or cholecystitis or cholangitis. And examples of complicated intra-abdominal infection could be same appendicitis, which could perforate, that is perforated appendicitis and causing peritonitis and abscesses, or cholangitis culminating into the biliary peritonitis. So now we will understand what peritonitis is. It is characterized feature. It is a very characteristic feature of complicated intra-abdominal infection. Peritonitis is described as inflammation of peritoneum caused by any irritant or agent such as bacteria, fungus, viruses, talc, powder, drugs, and foreign bodies. Anything can irritate the peritoneum and lead to inflammation of peritoneum, that is called peritonitis. But the most common cause is usually infectious. Infectious peritonitis is caused by the various microorganisms. It could be classified into primary, secondary, and tertiary peritonitis. So we will understand what they are. So the primary peritonitis is a bacterial contamination mostly caused by single bacteria without loss of integrity of the gastrointestinal tract, usually due to blood dissemination from any extraperitoneal source like lungs, like urinary tract, or it is usually seen in ascites with cirrhosis. Okay, so that is called spontaneous bacterial peritonitis. Or sometimes you see this in in patients who are getting dialysis through a very specialized peritoneal catheter that is called peritoneal dialysis catheters. And the mainstay of treatment in such kind of peritonitis is antibiotics and only antibiotics. Okay, and in severe cases, removal of the peritoneal dialysis catheter is important. So the important fact over here is that the integrity of the gastrointestinal tract or organ is maintained in primary peritonitis. Whereas in secondary peritonitis, there is a mechanical breach in the integrity of wall of abdominal organ. And usually this kind of peritonitis is polymicrobial caused by inflammation of peritoneum, and it could be the breach could be either in intestine or urogenital tract or solid organ like like gallbladder, okay, solid organ like kidney, which exposes the cavity to gastrointestinal flora, and that can lead to the peritonitis. Okay, the secondary peritonitis is further classified as the perforation peritonitis, which is caused by typhoid fever or mesenteric ischemia, or the postoperative peritonitis, which occurs due to anastomotic failure or anastomotic disruption, or sometimes it could be post-traumatic peritonitis also, where there is a mesenteric tear, a sharp weapon or firearm. So, what is the treatment of secondary peritonitis? Obviously, you have to do a definitive surgery along with antibiotics, and these patients usually come with the septic shocks. You have to resuscitate with fluid and vasopressors. So now, after having understood about the types of intra-abdominal infections and then peritonitis, and now the last in the types of peritonitis, we should know the tertiary peritonitis actually, which is the persistence of intra-abdominal infection beyond 48 hours after primary or secondary peritonitis is treated. So, so despite the treatment of primary and secondary peritonitis, the intra-abdominal infection persists, and that is the tertiary peritonitis. And the duration which is given in the literature is 48 hours. So 48 hours time frame you should wait, and beyond that, if it is occurring, that is definitely is a tertiary peritonitis. So it is more common in critically ill or immunocompromised patients who have multi-drug resistant organisms with mortality rate of 30 to 60%, and management includes on-demand laparotomy. Multiple laparotomy may be required along with antibiotics and cultures based antibiotics, directed goal directed treatment. Now we will understand what is the pathogenesis of intra-abdominal infection. So remember, the inflammatory response depends on the type of bacteria and the host factors, which could be genetic traits or comorbidities. Okay, so the bacteria are important over here. Some bacteria are very virulent. Some bacteria are not so virulent. Okay, some bacteria are multiple drug resistant. Some are not even bacteria. They may be fungi. Okay, which can cause intra-abdominal infection. So it depends on the type of microorganism first, and then host factor, like the patient who has diabetes or who has developed this chronic kidney disease may not respond to your antibiotic, may be on ventilator for longer time, may be in the ICU for longer time, may acquire certain other types of infections apart from intra-abdominal infections. So that's where the prognosis is altered and become worse when patient has lots of other host cofactors which can deteriorate the prognosis. So sepsis of abdominal origin is started by the outer membrane of gram-negative bacteria, and that leads to production of inflammatory cytokines like TNF alpha, IL-1, IL-6, etc. And these cytokines in turn lead to increased capillary leakage due to injury to capillary endothelium, and that leads to microthrombi formation, that leads to extravascularization of fluid from intravascular space to extravascular space. That can lead to tissue hypoperfusion and organ dysfunction, etc. So basically, this leads to the cascade of inflammatory process, widespread inflammation inside the body, and that is nothing but sepsis. So we should know what is the sepsis is. Sepsis is the dysregulated host response to infectious organism, infectious process, and that which is also or accompanied by the organ dysfunctions. Okay, and there is also vasodilation of vasculature, which can lead to hypertension, and that's where it becomes complicated. Okay, requires multiple treatment options. Uh, it has been seen that the mortality is higher with the high levels of TNF alpha and IL-6 in the peritoneal fluid. So it is confirmed, it has been confirmed that the peritoneal fluid is the primary focus of infection in case of intra-abdominal infections. Which organisms are most likely causes of this intra-abdominal infection? So there are plethora of organisms. A lot of organisms are involved. The dominant species in early sepsis are Bacteroides, Fragilis, and E. coli, with coliforms and anaerobes involved in abscess formation as the late complications. Anaerobic gram-negative bacteria are found in about 50 to 55% patients, and gram-positive account for 42.5% of intra-abdominal infections. Okay. Uh, Remember that gram-positive bacteria are more common in case of colonic perforations, and Candida also very common in the upper abdominal infections. They are found in 19.9, that is 20% of patients, with 60% of these cultures being Candida albicans. So if we talk about the fungal infection, the Candida is the most common in intra-abdominal infections, and in among the species of Candida, the Candida albicans is 60% commoner. The prognosis is poor when there is enterococcus isolated or Candida is isolated from peritoneal samples during culture. So remember all these organisms according to types of peritonitis as well, where gram-negative uh, bacteria are more common than gram-positive bacteria. And in secondary peritonitis, you would see more of anaerobic and gram-negative. And in tertiary peritonitis, you would see more of hospital-acquired organisms. There are various causes of intra-abdominal sepsis like acute appendicitis, ischemic colitis, Clostridium difficile colitis, pancreatitis, diverticulitis. Then there is typhoid, tuberculosis, uh, then there is cholecystitis, cholangitis, pancreatitis, then there is perforation. So lots of causes of intra-abdominal sepsis. These are non-traumatic causes. Then there are some traumatic laceration and perforations of intestines and other organs, solid organs of abdominal origin. Now we will learn about the risk factors for higher mortality in complicated intra-abdominal infections. What are those factors? We should look in the patient and be more cautious while telling the patient's relative about the prognosis. So these are the risk factors like delayed initial intervention. If the patient is coming to you in your facility beyond 24 hours, okay, of the first inciting event, that is abdominal pain, then definitely the mortality is going to be higher. If the patient is coming with the higher severity of illness, uh, very sick patient, you can say Apache 2 score, if you could do, is more than 15 or SOFA score more than 8, that's definitely going to be a bad risk factor. Then advanced age, more than 65, 70 years of age, definitely. Male sex also is a risk factor for high mortality. If the patient is coming to you with very low albumin level, that means that Lots of leaky endothelium, lots of extravasation has already occurred, and patient has gone to kind of irreversible stage of sepsis. If the patient is coming to you with the baseline poor nutrition, that's going to be again a very bad risk factor, and that kind of patient will require a lot of hospital resources, ICU resources to come out of ventilator, come out of ICU. Diffuse peritonitis is worse than localized peritonitis. So if there is guarding and rigidity, definitely the prognosis is going to be worse, and that will require multiple surgeries. Then inadequate debridement or drainage. That's also from surgical point of view. If the surgeon is not able to adequately control the source of sepsis, intra-abdominal sepsis, then also the mortality is high. Similarly, repeated surgery, repeated interventions can also deteriorate the prognosis of patient. Then in patients who are having underlying cancers, okay, then also the mortality is going to be worse. If the patient is having underlying uh, immunosuppression, okay, if the patient is on some immunosuppressive agent, or if the patient is having comorbidity like diabetes or CKD, which also is a marker of decreased immunity, then also patient is going to die more often. And also the patient who is resident of a nursing home, already receiving the treatment for some condition in a long-term facility, then also your mortality risk will be high. How will you diagnose such cases? It's very simple. You ask the history, you uh, do a proper and full complete examination of all the systems along with detailed examination of abdomen. That will show some signs of local inflammatory response. That will also give you some systemic inflammatory response signs, okay, like fever, tachycardia, and tachypnea. So there is one important sign which is often present in some conscious patient. They will tell you that is the Bloomberg sign or rebound tenderness. That is a clinical sign which is pain upon removal of pressure rather than application of pressure to the abdomen, and that is actually a sign of peritonitis, the diffuse peritonitis. In critically ill patient, it is quite difficult to elicit such signs, which are not always present due to, sedation, due to impaired consciousness, spinal cord injury, or if there is a suppression of immunity. Okay, the signs will be absent. So these are the focal signs and symptoms of various types of intra-abdominal infections, various solid organ and perforations, diverticulitis. All those, a lot of signs are there, and we should be aware of. And when patient comes to emergency department, we should be, trying to elicit such signs. As I would suggest to go for ultrasound straight away and go for CT scan. Don't waste time. But you should be aware of this. If you don't have the facility to, if you don't have time to shift the patient for imaging investigation, definitely you should be able to elicit such clinical signs to localize the pathology. That's very important. So I'm not saying that you should not do it. You should remember this and do it whenever required, whenever they are indicated, whenever you don't have facility. You must be, relying on your clinical skills. So what's the diagnostic workup, which I was talking about? So you must do arterial blood gas. That's very important. That will tell you whether how bad a patient is, whether there is a high in metabolic acidosis, lower base excess, high lactate level. Okay, you must do CBC. That will tell you the degree amount of inflammation inside the body, and also left shaped and thrombocytopenia. That will tell you how bad sepsis is. Then there are quite sepsis biomarkers like procalcitonin, CRP, IL-6. If they are available, you must do that to again quantify the degree of inflammation inside the body. Then, if you could get the peritoneal fluid, definitely you should be able to send that for culture. Okay, that's very important. That will help you to narrow down your antibiotics. Okay, which you have started initially as an empirical. empirical antibiotics. Okay, always do urine analysis to rule out UTI, pyelonephritis, and acute kidney injury. Then also you must do some liver function test and kidney function test, coagulation profile, etc. Then few imaging investigations are also there, like chest X-ray in upright position is must, which will show you the pre-air sometimes under diaphragm, most often the right side, suggestive of perforated hollow organ. You must be able to do ultrasound abdomen, which is there always with you inside emergency department or ICU. It will show fluid inside the peritoneum, and if you could take out that fluid, that will help you to diagnose whether this is a perforation or not, and what kind of fluid it is, whether this is a transudate or exudate, and you would be able to see on ultrasound inflamed and edematous organ and characterize, and then that will lead to further investigation, that is CT scan. So then you do either CT scan, plain CT scan, or contrast enhanced depending upon the kidney situation. And it's not always possible to do CT scan in a patient because patient is quite sick or hemodynamically unstable. So in that situation, the modality of choice will be ultrasound, initial modality of choice, imaging modality of choice. But either way, otherwise, if somebody asks you what is the diagnostic modality of choice in abdominal sepsis, that is definitely the CT scan. In few of the patients, there may be mesenteric ischemia. You may be suspecting. In such cases, you must do angiography. Okay, if ultrasound is not able to show you anything, if X-ray is not able to show you anything, if CT scan is also negative, normal CT scan, and the patient is still having, you know, pain in abdomen or tenderness in abdomen, or the patient looking sick, then definitely go for a CT or for angiography. That will show you vessels, okay, and mesenteric ischemia. But again, it may not be possible in sick and unstable patients. So then go for diagnostic peritoneal lavage in few of the patients, where you uh, make an opening in the peritoneum and push 5 to 10 cc of 10 cc of saline, and then you aspirate, and then you send it for analysis. If it is showing more than 500 per cubic cc of neutrophils inside the peritoneal lavage, that is suggestive of peritonitis. So how will you manage? On admission, you should first control ABC, that is general intensive care. So management of intra-abdominal infection is divided into general intensive care or specific intensive care. In general intensive care, you have to take care of airway, breathing, and circulation, as you do usually. Send all the routine investigation and specific investigation, radiological investigation, to find out the etiology, to find out the degree of deterioration inside the body. Then you start simultaneously the resuscitation using the sepsis 1 hour bundle, which consists of measuring the lactates, remeasuring it, administration of antibiotics after taking the appropriate blood cultures. Then you have to treat the hypotension with the appropriate amount of fluid and vasopressors, and use hemodynamic monitoring. Avoid overload of the fluid because that can lead to intra-abdominal hypertension. You have to apply Rose concept of the fluid. So remember Rose, ROSE, Rose concept of fluid. We will discuss about it later. And then you can do the functional hemodynamic monitoring, which will guide further fluid therapy during the management resuscitation. Then you have to you have to use early vasopressor to restrict the amount of fluid. Then if you could start the feeding, if there is a no antral breach, it is no secondary or tertiary peritonitis, definitely you could give the feeding. But if it is suspected that there is a breach, then definitely you should withhold the oral feeding. You can start a TPN, total parenteral nutrition, depending upon whether patient is very malnourished at a baseline. Otherwise, you have to wait for 7 days, okay, to start TPN. Then you have to give analgesia and sedation as needed. Thromboprophylaxis, head and elevation, ulcer prophylaxis, glucose control. All those are the parts of general critical care. Then come back to specific critical care or definitive, management of intra-abdominal infection, which is nothing but the source control and antibiotics. You must give specific antibiotics apart after getting appropriate culture reports, and you have to do source control. Now, the surgical source control is the gold standard of specific management of IAI, which consists of debridement, removal of device, that is device removal, drainage, and decompression of abdominal cavity. That we should always remember, and that can be done in either one sitting or staged manner. So people say it is better to go in a staged manner in patients who have higher Apache 2 or who are appearing very sick or hemodynamically unstable, rather than doing everything all together in the first sitting. No, you can do it slowly. So you can debride, or you can what you call source control in the staged manner, and that is called damage control surgery. So what are the antimicrobial agents which should be used in complicated intra-abdominal infections? So you must be aware of those, because these complicated intra-abdominal infections are deadly infections, life-threatening infections, and you have to start antibiotics appropriately, in time, and in right doses. So the choice of antimicrobials in complicated intra-abdominal infections depend upon two important factors. The first is the type of infections. Okay, whether this is a community acquired intra-abdominal infection, or whether this is a hospital acquired or nosocomial abdominal infections, whether this is a high risk community acquired or low risk community acquired. So you have to, guide your or select your antimicrobial agent depending upon the types of infections. Then the second important factor is the resistance of organism, means that whether there is any risk factor present for MDR, that is multiple drug resistance, in your patient, whether you have to look for MRSA or VRE organism. You should be able to predict that this patient is may be suffering with certain kind of resistant infection. So that's very important. So community acquired intra-abdominal infections, in these kind of infections, there are two categories: low risk and high risk community acquired infections. So in low risk community acquired infections, there are two options: empiric regimen, first line, and then combination regimen. In empiric first line regimen, piperacillin tazobactam is preferred, whereas in combination regimen, you can give third generation cephalosporin or fluoroquinolone along with metronidazole for the anaerobic coverage. So either you give cefuroxime or ceftriaxone or ciprofloxacin or levofloxacin in combination with metronidazole. In case of high risk community acquired infections, single agent regimen may be imipenem, meropenem, or doripenem, because these are high risk infections where the mortality risk is quite high. You should be using with a stronger and very wide spectrum agent covering ESPLs, okay, like like all carbapenems, in which meropenem is usually preferred over imipenem and doripenem. Then there is another, category where combination regimens are used in high-risk community-acquired infections, like cefepime, tazobactam combination, or ceftazidime, combination with metronidazole, that you can, give in your high-risk community-acquired intra-abdominal infections groups. So consider the use of vancomycin or teicoplanin in patients where you suspect VRE, okay, or you suspect the MRSA. In such cases, you have to start the vancomycin or teicoplanin. And in patients in which you cannot use BL/BLI or carbapenem combinations due to allergies, vancomycin plus aztreonam plus metronidazole can be used. So this is a specific important point where I would like to mention, where you cannot use beta lactams, you cannot use carbapenem due to certain types of groups of who have allergies to these beta lactams or carbapenem. Definitely you must go for triple combination, that is vancomycin, aztreonam, and metronidazole. In case of hospital acquired intra-abdominal infections, You can give either single drug regimen like meropenem, imipenem, doripenem, as we were giving in the um, severe category, okay, um, and of community acquired infections, okay, or in case of hospital acquired IAI, you can give combination regimen as well, like ceftazidime, cefepime plus metronidazole. So this is as akin to, this is quite resembling to community acquired, what you call high risk community acquired intra-abdominal infection, where the same kind of regimen you would like to give. Modifications to regimen may be indicated if there are risk factors present, like as I said, for MRSA vancomycin is preferred, okay. In case of vancomycin resistant enterococci, you may have to give linezolid or daptomycin. That's very important point you must know. In case of fungal infection, Candida is the most common. Okay, there are risk factors present, like for Candida, for like surgically treated pancreatitis, openly treated pancreatic collections, or heavy colonization with Candida, or if you have isolated Candida or yeast from the peritoneal fluid, then you must start with some antifungal agent. If the patient is stable, not severely ill, you can start with gluconazole. If patient is unstable hemodynamically, always use echinocandin, in which you can use caspofungin, micafungin, um, or endofungin. Okay. Obviously, amphotericin B should not be used as initial therapy because of high toxic potential of amphotericin B, especially the nephrotoxicity. Now, another important point is when to stop antibiotic. It's very important. I have seen people continue antibiotic for a very long time. It is suggested and it is recommended that you should not extend beyond 7 days. Okay, if you have achieved the source control properly. If you could have not achieve the adequate source control, definitely you have to extend your antibiotic and try to talk to surgeon and get the source controlled. Otherwise, you have to continue antibiotic and you have to do antibiotic cycling. You cannot use same agent for more than say 10 to 14 days. Okay, it will cause resistance. So in summary, intra-abdominal infection is an important cause of morbidity and mortality. And the cornerstone of effective treatment of intra-abdominal infection include early and accurate diagnosis using various diagnostic methods, cultures, and procalcitonin, inflammatory markers, etc. Then you have to begin the resuscitation early. You have to combine it with the adequate source control, damage control surgery, and simultaneously you should be able to initiate the wide spectrum antibiotic, and then later you must de-escalate the antibiotic to the narrow spectrum, okay, single agent. Then proper diagnosis of intra-abdominal infection with evaluation of risk factor is necessary to guide the selection of antibiotic and also prognosticate the patient. Early laboratory markers like TLC cultures and procalcitonin, and radiological marker like CT scan, radiological investigation like CT scan, ultrasounds are very, very important to complete the picture of problem, and so that you can prognosticate well, you can guide your treatment plan, you can plan your treatment. Then antibiotic stewardship obviously have to be considered in all steps of your management. There has to be multiple teams interacting with each other for these kind of patients who have very life-threatening infections, and obviously intra-abdominal infection is considered life-threatening many times. And early diagnosis and treatment failure and its management is very, very important. Okay.